Pediatric Cardiac Anesthesia mini-series. So today's topic is Truncus Arteriosus, one of the most fascinating and challenging congenital heart disease. Caring for those children demands a thorough understanding of anatomy, physiology, and surgical repair, and a meticulous perioperative anesthesia management. So every decisions we make can have a profound impact on the outcomes. So we are truly privileged to have Dr. Soumitra Mukherjee again with us today. His expertise and experience in pediatric cardiac anesthesia will undoubtedly help us to understand not only the science behind the complex lesion, but also the practical problems of managing these patients in the operating room and in the intensive care unit. So I encourage everyone to participate actively, ask questions, and make most of these interactive sessions successful. So without further delay, it's my pleasure to invite Dr. Soumitra Mukherjee to begin today's lecture. So the virtual stage is yours. Thank you so much.
So, good evening all. Today's topic of discussion is perioperative management of persistent truncus arteriosus. Although it's a very uncommon or rare variety of complex congenital heart disease, but its unique anatomy and the pathophysiology entailed us to know in depth about the anatomy and the pathophysiology. Then only we'll be able to manage in the perioperative period. So without further delay, let's start about the discussion on persistent truncus arteriosus. How it is defined? A single arterial vessel arising from the heart, receiving blood from both ventricles and supplying blood to the aorta, lungs, and coronary arteries characterizes the condition persistent truncus arteriosus. So, truncus arteriosus is a condition where a single blood vessel supplies the aorta, lungs, and the coronaries. The truncus arteriosus is most commonly associated with a large ventricular septal defect in the conal septum. And mostly it is malaligned VSD. The location or the anatomy of the VSD in case of every type of truncus arteriosus remains same. It is one of the conotruncal anomalies thought to result from failure of septation of the conotruncus portion of the heart tube during embryonic development. Difficult to understand, but when I will discuss the embryology of development of truncus arteriosus, this concept will get clear. How do we classify the truncus arteriosus? Truncus arteriosus can be classified in various ways. The time-tested classification is done by Collett and Edwards based on the origin of the pulmonary artery from the truncal artery. You can see in this picture, there are 4 types: type 1, type 2, type 3, and type 4. Now, what are the anatomical details of these types? So what is type 1? In type 1, an arterial trunk originating from the common semilunar valve with its immediate bifurcation into a pulmonary artery and ascending aorta. So coming to this picture, you can see in the extreme left, that is type 1, there is origin of one common arterial trunk from the semilunar, above the level of semilunar valve. Just after this origin, it is getting bifurcated into 2 different vessels. One is ascending aorta, one is main pulmonary artery. Again, the MPA is getting bifurcated into RPA and LPA. So it is the type 1 Collett and Edwards truncus arteriosus. What is type 2? Type 2 defects refer to the separate origin of the left and right pulmonary artery from the posterior wall of the truncal artery. So, in type 2, there is no separate origin of main pulmonary artery from the truncal artery. A common vessel is arising above the level of semilunar valve. Then after its origin from the posterior wall, there is separate origin of RPA and LPA. In type 3, it describes anatomy similar to that of type 2, but with the right and left PAs originating further apart from the side of the truncal artery. So you can see in this picture that in type 2 and type 3, they look almost similar. But the difference in type 3 is that in type 3, the branch PAs are originating further apart from the level of semilunar valve. At the same time, they are originating from the side of the truncal artery. Then what is type 4? Type 4, often referred to as pseudotruncus, the main PA is absent, with the lungs receiving their blood supply through aortopulmonary collaterals. Now, according to many researchers or many textbooks, they do not even consider the type 4 as a true truncus arteriosus. They often refer this category as pulmonary atresia with VSD, and the lungs are getting supplied by the aortopulmonary collaterals. So these are 4 types of Collet and Edwards types of truncus arteriosus. Coming to the another classification, that is the Van Praag classification. Initially, Van Praag classification classified the truncus arteriosus on the basis of presence or absence of VSD. As I have already mentioned, that mostly truncus arteriosus patients are having VSD, but in a very few patients, in very few percentage, there is absence of VSD also. So when the VSD is present, it is known as type A Van Praag, and when the VSD is absent, it is known as type B Van Praag. Again, Van Praag classification is reclassified, particularly the type A, into 4 subtypes: type A1, A2, A3, and A4. Frankly speaking, these subtypes of original Van Praag classification is more applicable in clinical practice for the classification of truncus arteriosus, because the surgical decision or surgical plan of management is being decided on the basis of modified Van Praag classification. So what is modified Van Praag classification? What is type A1? In type A1, main pulmonary artery arises from the common arterial trunk and then bifurcates into branch pulmonary arteries, exactly similar to type 1 of the Collet and Edwards classification. Then what is type 2? In type 2, there is absence of main PA, and the branch PAs arise directly from the common arterial trunk. Now, this branch PA can directly arise from the truncal artery, either from the posterior wall or from the side wall. So it includes both the type 2 and type 3 of Collet and Edwards classification. That is type A2, Van Praag classification. What is type A3? In type A3, left PA originates from the aortic arch and right PA originates from the common arterial trunk. Coming to this picture, in this picture, from the left, concentrate over the third one, that is the A3 or the type A3 or hemitruncus type, where you can see that the right one is originating from the truncal artery, and the left one from the aortic arch. So what is type A4? In type A4, the truncus arteriosus is associated with another very serious and complicated congenital heart disease, that is interrupted aortic arch. When interrupted aortic arch is associated with truncus arteriosus, it is known as type A4 of modified Van Praag classification. So coming to the embryology, initially there is no division between the pulmonary artery and the ascending aorta or aorta. So that common vessel is known as truncus arteriosus. Now within this common vessel, that is the truncus arteriosus, there is formation of truncal ridges from the wall of this truncus arteriosus during the 5th week of gestation, and gradually these truncal ridges become continuous with the conal septum, which is going superiorly. These ridges eventually fuse with each other to separate the truncus arteriosus into two channels, the aorta and main pulmonary artery. Now, the spiral formation of these ridges results in the normal orientation of the aorta and PA, with the aorta positioned posteriorly and to the right of the PA initially during the development. After that, the conus cordis gives rise to the left ventricular and right ventricular outflow tract. You all know that both the outflow tract, they are originating from the conus cordis, and after that there is formation of conal septum in between them. Ultimately, that conal septum and the truncal septum, they fuse with each other along with that truncal ridges to separate the channel from RV to PA and from LV to aorta. Persistent truncus arteriosus results from failure of the truncal ridges development and aortopulmonary septum development, and ultimately there is no division between aorta and the pulmonary trunk. But the mechanism for failure of the truncal septation remain unclear till date. So what is the exact anatomy? I guess that from the classification part, you have a fair idea about the anatomy of truncus arteriosus. But if we go in detail that about the anatomy, the segmental anatomy of truncal arteriosus can be described as situs solitus, a delooping ventricle, and a single great vessel arising from a common semilunar valve. The truncal artery overrides a large VSD with malalignment, and this type of malalignment is frequently malaligns to the right side. The truncal valve or the common semilunar valve has variable number of cars. Either it could be 2, 3, or 4. Commonly, there is presence of truncal valve incompetency causing significant regurgitation. Now, again, another very important aspect of the anatomy is the location of the coronaries, because the surgical plan of management will definitely change according to the orientation of the origin of coronary arteries and their anatomy, their courses. The origin of the coronary ostia and the epicardial course of the coronary arteries can be variable in truncus arteriosus. Then what are these variables? Coronary ostia can originate in various positions from within the truncal artery or as a single coronary artery with a variable epicardial course. Now, there could be anomalous origin of the left coronary artery from the right coronary artery. When this type of anatomy is present, that left main coronary will cross the right ventricular outflow tract. This is of particular importance when planning the construction of the RV to PA conduit. When the left main coronary ostium originates more superiorly in the commissure, care must be taken to avoid injury during separation of the PAs. You already know that in type 1, there is origin of PA from the truncal artery just above the location of common semilunar valve, and we have to separate that main pulmonary artery from the truncal artery. During separation of this MPA, we must consider the location of the ostium of the coronary arteries. Otherwise, there will be injury. The pulmonary artery branches are usually of normal caliber, without any stenosis. However, stenosis of the origin and diffuse hypoplasia can occur infrequently. Coming to the pathophysiology, the blood from both the left and right ventricle is ejecting directly into the truncal artery. That is a common channel. Now, the systemic and pulmonary venous blood mixes over there, and the arterial oxygen saturation depends on the amount of pulmonary blood flow. Pulmonary blood flow may be limited by the stenosis of the PAs, but I've already mentioned this is uncommon. In most instances, the pulmonary blood flow, thus the arterial oxygen saturation, is determined by the resistance to flow to the pulmonary vascular bed. Now, what happens in the initial newborn period, when the pulmonary vascular resistance remain high, the flow through the pulmonary bed is restricted, is limited. That will cause dip in arterial oxygen saturation, and there will be certain amount of mild to moderate degree cyanosis. But when the child is growing beyond few days of the newborn age, gradually the PVR decreases. When the PVR decreased, there will be torrential blood flow through the pulmonary vasculature. Ultimately, that cyanosis is gone and congestive heart failure induced. So after the second week of life, when the pulmonary vascular resistance decreases, pulmonary blood flow may become torrential, leading to volume overload to the left ventricle, pulmonary edema, and decreased system oxygen delivery. The child is seen in florid congestive heart failure. Over time, the continued exposure of the pulmonary vascular bed to this flow leads to the development of pulmonary vascular obstructive disease, just like any kind of significant left-right shunt. The pulmonary vascular resistance increases gradually, and the pulmonary to systemic ratio approaches 1 or less than 1. The child then has signs of cyanosis, there is reversal of flow. A point is reached at which these changes become irreversible, and definitely this time the condition is also become inoperable. So what about the natural history? Natural history for survival without intervention is poor in children with Truncus Arteriosus. Without surgical repair, only 50% survive beyond 1 month, 30% survive beyond 3 months, 18% survive beyond 6 months, and only 12% survive beyond 1 year. But children who is surviving to 1 year of age do so because of pulmonary artery stenosis, although it is very uncommon. And therefore, protection of the pulmonary vasculature from exposure to systemic arterial pressure and consequent decreased risk for development of pulmonary hypertensive vascular changes, that is pulmonary vascular obstructive changes. Cause of death during neonatal period is congestive heart failure from torrential large left-right shunt or significant truncal valve regurgitation. Presenting symptoms include features of heart failure in the first few weeks of life, consisting of tachypnea, tachycardia, irritability, poor feeding, and poor weight gain. Mild cyanosis may be present from decreased pulmonary blood flow due to either pulmonary artery ostial stenosis or high pulmonary vascular resistance. That is usual in neonatal period, as I've already discussed. Gradually, cyanosis resolves when the PVR decreases. In older children, again, cyanosis develops due to Eisenmenger syndrome. Coming to the investigation part, according to the type of Truncus arteriosus, the chest X-ray finding differs. There will be marked cardiomegaly and pulmonary plethora in most infants, which is common to all types. If there is absent, if there is no PA stenosis, but in type 1 truncus, there may be a normal PA segment visible, But in other types, the PA segment, as the MPA is absent, the PA segment is diminutive or absent, giving the appearance of narrow superior mediastinum. So on the left-hand side in picture A, you can see there is wide mediastinum, that is type 1 Collet and Edwards Truncus arteriosus. On the right-hand side, there is narrow superior mediastinum because of absence of MPA, which can be either type 2 or type 3. Coming to the echocardiogram, echocardiogram is very, very important. Most of the anatomical details can be obtained from thorough echocardiogram with a skillful hand. So what could we see in the echo? There will be demonstration of single artery from the originating from the from both the ventricles, conal septal VSD overriding the truncal valve, then truncal valve anatomy, the number of valve clasp, the presence of any incompetency of that truncal valve present or not, the origin of the pulmonary arteries, the stenosis of the pulmonary arteries is present or not, then whether there is in presence of PTA or other associated anomalies, including interrupted aortic arch, whether there is any anomaly of the origin of the aortic arch branches, abnormalities of the detailed abnormalities of the coronary artery origins, because accordingly the surgical plan of management will be decided, whether there is any persistent LSVC, additional VSD, which is very uncommon, but whether there is any, they are present or not, and associated tricuspid and mitral valve anomaly present or not. So these are the anatomical details which we must get from the transthoracic echocardiography. Coming to the MRI, MRI is a non-invasive and it will be useful in the following situation: when there is the echocardiography findings cannot determine the exact anatomy in detail, and there is difficulty from difficulty in differentiation from the outer pulmonary window, the MRI will be helpful. Now, what MRI will extra guide us, that will give us extra information about the origin of the pulmonary artery, the origin of the aortic arch branches and their little anatomy, the branching pattern. So, and definitely the pulmonary artery branches, whether there is any stenosis is present or not. So, what is the role of the cardiac cath? In neonates and infants, cardiac cath is only required when echo and MRI do not provide the information necessary for surgical planning. So till now, you can understand that echocardiogram is an useful tool to have the clear idea about the anatomical details. When it is not helpful, MRI can be done, and when both echo and MRI are not helpful, then comes the utilization of the cardiac cath. When we are doing the cardiac cath, the catheter usually passes easily from the RV to the truncus arteriosus and into the either branches of the pulmonary artery or via the PDA into the descending aorta. So coming to the medical management, now patient has been posted for the surgery. Once the diagnosis has been made, about the medical management, infants and children who are slightly cyanotic and do not have any features of increased pulmonary blood flow, the active therapy may not be necessary. But when there is increased pulmonary blood flow and congestive heart failure, therapy is indicated to address the heart failure. What about the surgical plan of management? Patients too small for full repair may undergo PA bending while awaiting for the definitive repair. Now, what are the principles for definitive repair? Number 1, closure of the VSD. Number 2, separation of the pulmonary arteries from the common arterial trunk. Number 3, connecting connection of between PB, right ventricle and PA through a conduit, closing of the defect within the common arterial trunk by a patch. And usually the truncal valve does not require any surgical intervention until unless there is significant regurgitation or incompetence is present. Coming to the CV bypass related issues, the aortic cannula is placed near the base of the innominate artery to allow sufficient room for the aortic cross clamp above the origin of the branch PS from the common arterial trunk. Why it is so? Because then if we do not follow this policy, the flow we are giving from the CV bypass will go towards the pulmonary arteries and less amount will flow through the systemic arteries. If truncal valve insufficiency is present, the cardioplegia may cause LV distension. In that case, direct administration of into the coronaries are required. The pulmonary arteries must be controlled before or soon after the commencing bypass, since runoff to the pulmonary circulation can compromise systemic perfusion. You can see in this picture about the surgical management. On the left hand side, the RV and the aorta and the PA are separated. Then the new aorta is formed with a patch closure. The RV to PA conduit is established. Then on the right hand side, you can see that these surgical steps are followed when there is significant truncal valve regurgitation, because there you cannot keep the incompetent truncal valve. You have to replace it with an allograft, and then the coronary arteries are reattached over that allograft. The rest of the surgical plan remains same. What about the anesthesia technique? The association of Truncus arteriosus with facial abnormalities, which is quite common. We have to consider it whether the management of airway will be difficult or not. Accordingly, the plan is prepared. There is frequent association of thymic abnormalities. If it is at all present, we have to change our plan of anesthesia management because this thymic abnormality is associated with T lymphocyte dysfunction. There could be associated parathyroid hormone dysfunction, which may cause hypocalcemia. And when we are while we are coming off from the CV bypass, calcium infusion is mandatory in these cases. In the preoperative period, the degree of heart failure to thrive, pulmonary hypertension, the degree of cyanosis, and the evidence of coronary ischemia must be addressed. During induction, propofol and nitrous oxide are usually avoided. Careful hemodynamic monitoring and appropriate measures are taken to adjust the PVR and SBR and cardiac contractility, which are of paramount importance rather than selection of a particular anesthetic agent. So while we are inducing the patient and managing the maintaining the anesthesia, we have to adjust the PVR and SBR ratio, which is most important, because according to the, particularly in the pre-bypass period, how we are managing the PVR and SBR, that will dictate the adequacy of maintenance of anesthesia, but because accordingly the pulmonary blood flow will change. Control of PVR is important when we are inducing the babies in Truncus arteriosus. The usual problem will be excessive runoff from the systemic circulation into the pulmonary circulation, because if during induction the PVR is lowered at significant level because of high inspired oxygen, high FiO2, then there will be excessive pulmonary blood flow. Again, patient will go into heart failure. So hypotension associated with a relatively high SpO2 with lactic acidosis or ischemic changes because of lack of systemic blood flow on ECG suggest that lung is flooded with excessive blood flow and the heart failure is developing during the induction. So whenever there is this type of situation, we must be aware about this situation. So while we are inducing, we must keep the FiO2 at lower level. The target SpO2 throughout the induction and maintenance period is around 70 to 80%. That level of SpO2 is sufficient enough to have the to maintain the adequacy of systemic oxygenation. Lung blood flow may be restricted by ventilation strategies, the strategies that increase the mean airway pressure, ultimately leading to decreased pulmonary blood flow, such as the example is application of judicious PEEP. So our every effort during the induction and maintenance is to balance the SBR-PVR ratio to keep the QPQS ratio mostly at 1:1. If surgical access is available, that is, the surgeon has opened the pericardium, mechanical restriction of the pulmonary arteries with temporary, partially occlusive vascular snares may establish hemodynamic stability in the pre-bypass phase by restricting the pulmonary blood flow. Unless ruled out by a chromosomal evaluation, patients with Truncus arteriosus should be assumed to have Digeorge syndrome with hypocalcemia and should be given irradiated blood product due to the high incidence of associated T cell deficiency and calcium infusion. There could be ventricular fibrillation due to myocardial ischemia prior to the bypass. I've already mentioned, because of excessive pulmonary blood flow and decreased systemic blood flow. And the anesthetic and surgical team must be alert during the pre-bypass period about this possibility and be prepared to intervene with external or internal defibrillation with open or closed cardiac massage or emergency commencement of the CP bypass. Coming to the post-operative management, there is a high possibility of pulmonary hypertensive crisis, that is PA crisis, and frequent episodes of low cardiac output in the post-operative period. Accordingly, these two conditions should be managed. The intraoperative placement of PA line and the left atrial line, LA line, will assist in the post-operative management of these potentially fatal events. It is often useful to leave the sternum open, the chest open, until the pulmonary compliance recovers, since premature closure of the chest can create pulmonary tamponade with compression of the conduit and decreased filling of the right heart. For infants refractory to conventional attempts to reduce the pulmonary resistance, ECMO may be initiated during the immediate post-bypass period. RV dysfunction is quite common, which may result from elevated pulmonary pressure, insufficient preload relative to a stiff, non-compliant RV, metabolic derangement, volume overload secondary to residual leftover or left-right shunt, or compression of the coronary arteries due to RV to PA conduit. And this presence of low compliant RV necessitates keeping the CVP at a slightly higher level. The patients must be ventilated at the lowest airway pressure possible in the post-bypass period, because increased intrathoracic pressure will have a detrimental effect on ventricular filling and output. As I already mentioned, that the RV is stiff and non-compliant. To optimize the cardiac output, pacing at a rate, DDD pacing at a rate of 140 to 160 per minute is accomplished with epicardial pacing. And as I mentioned, that post-operative low cardiac output is very common and we are keeping the chest open. So it is preferable to keep the inotropic support for the initial 24 to 48 hours. And once the chest is being closed, we must keep that inotrope for another 24 hours to see how the ventricles are behaving once the chest is being closed. After that, gradually we can wean off from the inotropic support. That's all. Thank you.